Good afternoon. Welcome to our webinar about biomarker testing for non-small cell lung cancer and small cell lung cancer. I am your host, Rachel Dasic, Senior Director of Education at the Cancer Support Community. For more than 35 years, we at the Cancer Support Community have been a relentless ally for anyone impacted by cancer. We help provide emotional support and give people the knowledge to be active partners in their own care. You can access our free services in person at one or more of one of our 175 locations, online, or over our toll-free helpline. You will be able to work with a team of licensed professionals who can provide patient navigation, financial counseling, genetic counseling, and much more. Today, we're excited to discuss a very important topic, biomarker testing, and how it is being used to find treatment options for many people with non-small cell and small cell lung cancer. Until recently, many lung cancers were treated the same, but biomarker testing has changed that significantly. Today, you will learn what biomarker testing means for you if you or your loved one has been diagnosed with non-small cell or small cell lung cancer. We'll talk about how testing positive for a biomarker may lead to more targeted treatment. And we'll also address how to talk about biomarker testing with your healthcare team. But first, I am excited to introduce our guest speaker, Dr. Sanja Dacic. Good afternoon, Dr. Dacic.
Good afternoon, Rachel.
Thank you for joining us. Dr. Dacic is a professor of pathology in the Department of Pathology at the University of Pittsburgh, director of anatomic pathology at UPMC Presbyterian Hospital, and director of Thoracic Pathology Center of Excellence. Dr. Dacic received her medical degree and a Doctor of Philosophy degree at the School of Medicine, University Zagreb in Zagreb, Croatia. She completed her residency training at the University of Pittsburgh and joined the faculty immediately after her fellowship in surgical pathology. Dr. Dacic is focused on diagnostic, pulmonary, and molecular pathology and has been involved in many basic and translational research projects in lung cancer and pleural mesotheliomas that have resulted in numerous peer-reviewed scientific articles, book chapters, and reviews. She was also a co-author of the original and revised CAP IASLC AMP guidelines for molecular testing in lung cancer. Dr. Dacic was a member of the editorial board for the 5th WHO classification of thoracic tumors. She has been an officer of the Pulmonary Pathology Society since 2006 and is currently serving as president. Dr. Dacic is a member of the US and Canadian Mesothelioma Group and the International Mesothelioma Panel. Welcome, Dr. Dacic. Thank you for joining us here today. I feel privileged being able to speak to you. You're definitely an expert in the field, and I'm very excited for our conversation. So Dr. Dacic, I have some questions I'd like to ask you so we can better understand what biomarker testing is and why it's so very important. Then we will get some questions and ask some questions from our live audience. Does that sound okay to you?
That sounds perfect. And Rachel, I would just like to use the opportunity to thank you again for inviting me to be part of this wonderful discussion, which I think is very important for our patients. I'm very happy to be part of this program. Thank you so much.
Thank you. So let's begin. Can you tell us the basic understanding of what a biomarker is?
Yes, that's an excellent question because we all talk about biomarkers all the time, but the question is what the biomarker is. And a biomarker is a sign of disease or sign of abnormal function. And we can actually measure biomarkers in blood, in a tissue or in a body fluids. And when we are speaking about cancer, biomarkers are often used to help us to choose the best treatment for you, because some of the biomarkers, and we'll speak more into details a little bit later, are actually targetable nowadays, and we do have a treatment for those. So the other terms that you can hear from the healthcare team may also be tumor markers, cancer markers, or molecular markers. And there are different examples of biomarkers in lung cancers. We can talk about genes, different genes, and change in those genes. That could be there. You can also hear mutation of the certain gene or fusions of the certain genes. And there are also some abnormal proteins that are results of those abnormal functions of the genes that we can also detect by different assays. So what's actually important to know about the biomarker testing is that when we are looking for the biomarkers, we are actually trying to gain the information of what can actually cause a tumor to grow or further expand. And based on that knowledge, actually, in a huge research field, we were able to develop different targets, different medications, drugs that are now on the market that actually can help and prevent the tumor growth and, in a way, help our patients.
Okay, so thank you for breaking that down for us. So if your tumor tests positive for a biomarker, what I hear you saying is that it can tell your healthcare provider what your unique subtype of lung cancer is. Is that correct?
That is correct. That is correct, because different tumor types will have different biomarkers that we can actually use to, in a way, to diagnose the disease, and as well as to identify what's the particular abnormality that actually can be treated. So yes, we can use this for the certain diagnosis, if you will, of the certain tumor type.
That's truly amazing. So it's amazing, and I'm sure you've seen it, how far science has come to help us with this.
That's correct.
So please tell us, Dr. Dacic, how a biomarker test is done.
There are different ways how we can do the biomarker testing. They could be done. First of all, we need to obtain a sample from the patient, and that sample could be obtained, for example, at the time of the diagnosis. After patient is referred, for example, for different diagnostic procedures like biopsies, the tissue that is taken from the tumor could be sent for the molecular testing. The other way is, for example, when the surgery is done, we are getting much larger samples at that time, and those tissue samples, again, can also be sent for the molecular testing. So there are different assays that we can do and perform on these different types of the specimens. There are other ways how we can do it, or other samples that we can use. For example, body fluid. If somebody has a fluid in the chest cavity, we can drain that fluid, and we can also send that fluid for the testing. And most recently, we've seen a lot of testing done on the blood for these biomarkers. And that's another way, usually the easiest way, although there are differences between different tissue samples, but that's another way how we can test. And then we can, there are different assays that we can use. We can use the assays to detect certain abnormal proteins. We can look at the genes, gene levels, looking into the DNA abnormalities. We already mentioned some of them, for example, mutations or gene fusions that could be detected at the RNA level, for example. And very frequently, you are going to see these biomarkers in our pathology reports or reports from different molecular laboratories using like a 3 or 4 characters abbreviations, such as ALK, such as EGFR or PD-L1.
Okay. So does everyone diagnosed with lung cancer, does each person get biomarker testing?
Biomarker testing landscape is quite variable, and unfortunately, not all of the patients will get a biomarker testing, but there could be different reasons why biomarker testing is not performed or not offered for the patient. It's a very complex decision process, and certain factors play a role, such as availability of the testing, access to the testing, whether patient is a candidate for the testing, depending again on the tumor type, depending on the tumor stage, There are various reasons. So it's not something that's automatically is going to happen. For example, like usual blood test that you can get when it's just sent to the chemistry lab. That's not the case here. So there's a decision process. But it's actually very important for the patients to speak to their health providers about biomarker testing, because it's important to find out and know whether you as a patient actually qualify and meet all of the criteria that we as a healthcare provider know what criteria are for the biomarker testing, and bring it up if it's not mentioned in the initial time of the diagnosis when the conversation about your disease and possible treatments is brought up. So that's the time to talk to your healthcare provider and ask whether you are a candidate for the testing. Why is that important? Because I think, Rachel, you mentioned at the beginning, lung cancer used to be seen as a one disease and all patients would get the one treatment. That's not the case anymore, because there was so much advance in the scientific work that we learn more about the tumors, and actually we can have personalized approach to every single tumor type. And based on their biomarker profile, if you will, and this is essentially genetic landscape of the tumors. And if we are able to detect certain of these abnormalities, actually there are some FDA-approved medications where, again, depending on a patient's stage of the disease and other clinical variables that oncologists will take into consideration, maybe deciding points whether patient really qualifies for those certain targeted therapies. And this is basically when we are talking about personalized medicine, that basically means we are talking about biomarker profile of the patient's tumor that can then receive personalized treatment. And it's, I think, worth mentioning as well that those treatments are, and again, I have to say, I'm not treating patients, but I know from the literature and from the tumor boards, what I learned as a pathologist, these therapies are usually very much better tolerated than the chemotherapies. Basically, they really improve patients' quality of life, because that's really very important factor for those medications. And I should say that biomarker testing and targeted therapy really changed our thinking about lung cancer. We really thought about once someone is diagnosed with the cancer, this is actually deadly disease. Unfortunately, it is still deadly disease. But with this biomarker testing, targeted therapies, personal approach, we are getting into the era where actually we can treat the lung cancer. We may not entirely cure it, but we can treat the patients, improve their quality of life, and basically, prolong their lives and their life with their loved ones.
Thank you. Everything that you said is extremely empowering and a lot of information. And I think what's really important that you hit on, Dr. Dacic, is that we want to empower our patients and our loved ones and everybody that's listening to ask their healthcare providers, ask your healthcare team. Each cancer is different. And even if somebody else that you know is diagnosed with a lung cancer, their treatment may be different based on what you said, Dr. Dacic, but ask the question for sure. Okay, so as mentioned earlier, just so I make sure that we understand correctly, biomarker testing is available for those with non-small cell lung cancer and small cell lung cancer. Is that correct?
That is correct. That is correct. Biomarker profile testing could be slightly different, but yes, we can test for all tumor types, essentially for the lung cancer.
Okay, so can you start us off by focusing on biomarker testing for advanced non-small cell lung cancer?
Sure. So when we're talking about advanced non-small lung cancer, you may hear from your providers that there's so-called like a limited panels or kind of like mandatory genes that we should be testing, and there are also some expanded panels. And that's kind of like two ways you can hear about the biomarker testing. But I think all of the guidelines that are currently in the practice for the clinicians, as well as for us as a laboratory personnel, they include at least 9 biomarkers. And we should say these are the must for any panel of a biomarker testing. And we listed them here in the alphabetical order. But the first 2 were ALK and EGFR. These are the 2 oldest biomarkers. And we used to do kind of like a single test for each one of those biomarkers. Nowadays, we live in the era when we have a very powerful test, when we can test for multiple genes, multiple abnormalities, and it's important to say it's a one-stop. So we can take a drop of your blood or piece of a tumor tissue, put it through the machine essentially, and we can give you the information about many of those biomarkers. But those 9 listed here, as I said, ALK and EGFR is the first one, followed with the BRAF, KRAS, and MET, then some others, ROS, RET, and TRK. I know they sound very complicated, but these are kind of the abbreviations that you're going to hear. And I'm not going to try to explain what these abbreviations means because that would confuse you even more. But it's important at least to remember these are kind of like those buzzwords, buzz names that you can hear. And the most recent one that you may hear from your provider is a PD-L1. So these are kind of like a core 8-9 markers that every single cancer type should get done again in the appropriate clinical context. I'm not saying that everybody will qualify for this testing because the decision tree is more complicated. But again, I cannot emphasize enough. It's very important that your healthcare provider did mention this testing to you. You should ask about it.
Okay, that sounds absolutely reasonable. So as you indicated, Dr. Dacic, there are U.S. Food and Drug Administration FDA-approved drugs to treat each of these biomarkers. So we're going to break it down and talk briefly about each one at this point. Can you start us off by talking about ALK, which is ALK, is that correct?
Yes, ALK. Yeah, it's easier. So I can start with the ALK, or anaplastic lymphoma kinase. ALK is a gene which is involved in the cell growth, and the mechanism of gene function, alteration of a gene function here is a little bit different than, for example, EGFR, which is the second on our list. Here we are talking about basically that this gene can fuse with another gene. So there are like a different gene partners when we are talking about. And that can actually cause that this cancer will grow even more because now you have like a normal gene function. So I'm not going into too much biology because I'm trying to make it simple, and I'm not sure if I'm doing a good job here.
No, you're doing great. It's a very complicated subject, and you are on a roll.
Thank you. So it's really complicated, but the bottom line is like you get alteration within the gene, which results in the abnormal gene function, which results in uncontrolled tumor growth. And luckily enough, there are drug therapies, FDA approved drug therapies. We call them tyrosine kinase inhibitors. And you may hear that from your provider. There's tyrosine kinase inhibitors, or so-called TKIs is the other abbreviation that you may hear, that can actually treat ALK-positive lung cancer. And here I can say we have multiple generations of these drugs because these drugs were discovered in 2005. So we are talking about, what, 16 years now already? I even cannot believe that it's been like 16 years already. But every generation is actually improved because the landscape of these drugs is a little bit different because, tumors are very smart. So they can develop resistance to these drugs and they can find ways to kind of like grow again. But we are smart as well, so we modify these drugs and we try to target the tumor again. So there are multiple options, but your healthcare provider, your oncologist, they're very knowledgeable about these drugs and they can lead you through this entire process. So I'm actually very excited in that area, what's done for our patients, because it really has an impact on survival. And I cannot emphasize more enough impact on the quality of care or quality of life.
Okay. So go ahead.
No, I just wanted to mention like an EGFR because I don't think I mentioned about EGFR, which was on the slide. EGFR was the first one that was discovered, and this kind of methodology was used for the TKI markers, and when actually this whole knowledge about TKIs and tyrosine kinase inhibitors involved and started.
Yep. Well, you led right into my next question. So the next biomarker, EGFR, just like the initials, stands for epidermal growth factor receptor. Yes. So EGFR is a protein involved in cell growth. Is that correct? And can you explain it a little bit more for us?
That's correct. I mean, it's a very similar what we talked about ALK, and that we're going to talk about some other genes as well. Essentially, you get the alterations within the gene. In this case, we are talking about mutations. So the gene becomes abnormal. and start producing too much of the EGFR protein that again has an impact on the tumor cell growth. It has an impact on the tumor cell migration because they can metastasize. As we all know, unfortunately, these tumors may spread from their primary side. They may start in the lung, but they can very fast spread to the other organs like liver, brain. But luckily, again, we do have drugs that target those genes or abnormalities of those genes. And it's also important to say, again, as we mentioned for the ALK, these drugs have been around for like 15, 16 years now. There were these initial clinical trials. They really took a long time, but they were a really great learning experience for us. And we learned how to actually modify these drugs, what information is important, how to find the right target, how to develop right assay, how to test for those. And as I said, science is evolving. And, as I said, for the ALK, tumors are smart. They are basically new, they're changing and they're growing, but we also have drugs. Now we have, I think, like a 4th generation of EGFR inhibitors that are actually targeting those resistant drugs. So my message here is like, even your tumor may start growing again. And we didn't mention that at the beginning. This is when your healthcare provider will probably talk about retesting this tumor to look for the resistance, which means that we cannot target the tumor with the drug that we have. But when we find another mechanism, again, we are looking at the gene level. We may have another drug that's available. Usually they're FDA approved, and we can target those, we can target with a different drug again. So you may not get just initial testing. You get multiple testing during the course of the disease.
That makes sense. So next up is BRAF. That's the gene that makes the BRAF protein. Can you talk a little bit about BRAF for us?
BRAF, very similar story to EGFR. Again, it's always the same. We're dealing with mutations, abnormal genes, and again, growth of the tumor. BRAF was first where it was actually discovered and where therapy change was actually melanomas and the thyroid cancer. And then the similar discoveries we find in the lung cancer, so we can target lung cancer. It's a very small number of lung adenocarcinomas that are going to have BRAF alterations. We're talking about 2 to 5%. And this is something that I think it's also important to mention, for example, for ALK, for EGFR. EGFR in Western populations, so in our US patients, will be like about 10% to 15% of our patients. ALK is about 2 to 5%. So, this is not that everybody will have it, but that's even more reason to test and identify those patients who are really going to benefit from those type of the therapies.
Okay. The next one I wanted to talk about with you is KRAS.
Yes.
So if you have non-small cell lung cancer and your tumor tests positive for this biomarker, then would that mean you have KRAS positive lung cancer?
Yes, this is actually one of the latest developments in the lung cancer targeted therapies, if you will, because KRAS is one of those genes that's very frequently seen in smokers, in the patients who develop the lung cancer, primarily lung adenocarcinomas, and they have a history of smoking or they're still current smokers. And in US, that's the largest population. We're talking about 30 to 40% of the patients. And until KRAS drug was developed, we actually didn't have a good, good targeted therapies for that population. So the development of KRAS inhibitors, it's huge. It's absolutely huge because this is our largest population. And I have to say, there are different mutations that these genes can have. And unfortunately, at this time point, we have only one mutation, which is the most common, I should say, in the KRAS gene, which is, as it's stated on a slide, G12C. So if the tumor has a G12C mutation, we do have a drug. But if you have a G12D mutation, for example, and I'm not going to go into all explanations why we are using these abbreviations, we unfortunately don't have drug yet. That doesn't mean that we're not going to have it. I'm really a believer in science, so I'm sure we'll have it eventually. But this is at least the first step that we have something to target KRAS, which is absolutely the largest proportion of our patients that carry, or tumors of our patients that carry this type of mutation.
Okay. So next up is the MET biomarker.
Yes, MET is also, it's been around for some time now. And it's also another very exciting, I shouldn't say very exciting, I'm excited because we have a therapy for this alteration. And also very similar again, I don't want to say again the same thing, a mutation in the gene, abnormal, this uncontrolled growth of the tumor that we can now prevent by the drugs that we have out there. I'm a pathologist, so I have to say there's one particular type of the lung cancer that patients may see in their reports. When you get your report with the diagnosis, it may say sarcomatoid carcinoma. So this is one just of many, many subtypes of a non-small cell carcinoma that we can diagnose. And we are trying to be really very precise in our subtyping because it does have impact on the treatment and decision process. But that's the one that actually have met so-called exon 14 mutations in 25% of cases of those tumors. So it's very common. So if you're diagnosed with sarcomatoid carcinoma, I think you should really ask whether you are going to be tested for the MET, because sometimes provider can say, we're going to test you for EGFR, ALK, and ROS only, because these are kind of like the oldest and traditional markers that we had. And in some practices, some providers may think that's sufficient, although I would say like a knowledge is really growing and that could be more kind of exception than the rule that you're going to hear. But if that happens to the patient that you're just offered those three, please, and you have the diagnosis of sarcomatoid carcinoma, make sure that you ask, am I going to be tested for MET as well? Because this is a very common finding in those type of the tumors, and with a really great results in terms of like a shrinkage of the tumor and again, quality of life of our patients.
That's really good information. So we should always push our healthcare providers to make sure that they're doing the most possible and to never be fearful about asking those questions. Dr. Dacic, I know this might be a little bit out of your terrain, but with all this testing, do you have any sense about how insurance is covering it? I know that that's always a concern for patients.
That's a huge concern, and it really depends on the provider. We in a pathology feel that very much because we are doing this testing and we are not getting paid for it. But I think we are getting in the right direction. Medicare is basically paying for many of these markers and many of these tests. Usually when we are talking about these limited panels, coverage is pretty good. Once we start getting into these large comprehensive panels with like 300, 400 genes, that's when it becomes an issue. So,
sure.
If there are any financial concerns, I think it's very important to talk to your insurance, to talk to your provider. They can provide a justification. It's a very, I should say, for me as a physician and a human being, it's a very painful and emotional process, could be. And because I personally believe that everybody should be able to get this testing, but to prevent these, because these tests are expensive, they're not very cost effective.
That's right.
Not cheap. So we may talk about a few $1,000s here, which could be huge for many of our patients. So I think it's important to talk to your insurance. It's important to talk to your provider to provide a justification for that testing. There are other options how we can go. I'm not advocating anybody here. I'm not advertising anybody here. There are certain commercial labs that can provide financial support as well, but I think it's important to be informed about this aspect, unfortunately, about this aspect of our healthcare, because it can have a negative impact on our finances.
Well, you seem passionate about that, as we are a cancer support community, to make sure that our patients are getting everything possible and to ask all the right questions. And there's also, your lung navigator who can help steer you in the right direction, financial navigators, your oncology social workers. So never fear about asking for help. Often hospitals, they might have a program to assist you. And like Dr. Dacic said, there might be payment options out there through, companies, all sorts of different options. So don't hesitate to ask your healthcare team. And you can also call us a cancer support community, and we can help steer you with what those right questions are. So the next biomarker, similar in sounding to MET, is RED. And that's a gene that plays a role in cell signaling.
Yes. This last group of the genes, the RET, ROS, NTRK, I know they sound like terrible, but they have a little bit different mechanisms of mechanisms, let's see, of their alterations. So for the prior ones that we mentioned so far, except ALK, we were talking about gene mutations, so changes in the DNA. Here we're talking about genes fusions. So these genes, like all three of those, RET, ROS, NTRK, they're going to fuse with different other genes. So we usually can hear the term gene partners, they're different gene partners. And again, the mechanisms are very similar. What it leads to is abnormal gene function. And again, unfortunately, these tumors grow then. But these three are example of that we can target them. Again, we do have FDA-approved drugs, and RET and ROS are the ones that were approved in lung only initially. But for example, NTRK was tumor agnostic because it's a very uncommon event. Only 1% of lung cancers will have NTRK abnormalities. And the results where we learn, because it can occur in other tumor types, for example, in different sarcomas, it was approved for different tumor types, and lung was one of them. And testing is slightly different for these. You may hear about like a fish testing, it's a very powerful test. We can also use, just to stain the slide, but these are like not reliable. So you can hear about immunohistochemistry for detection of the proteins, but these are usually not reliable and really have to go for the molecular tests. And I cannot emphasize enough how these comprehensive panels are actually very valuable to us, because we can, as I mentioned earlier, from a drop of the blood or 2 millimeters of tissue, we can test for hundreds of genes and give you very valuable information. But most importantly, these three drugs that are on this slide right now, or genes, we can target them. We can target them. They're uncommon again. These events are not common. They occur in 1 to 2% of patients, usually with the lung adenocarcinomas. But they do occur, and again, we cannot emphasize enough how important it is to test for those, to find those patients who can actually benefit from the therapy.
Okay, so with ROS1 and NTRK, you already touched on them. Anything else you want to say on them, or should we go on to PDL1?
I think we can move to PDL1, because with these like a tyrosine kinase kinases or tyrosine kinase inhibitors, it's pretty much similar, mechanism of alterations, pretty much similar drugs that we use, same testing platforms. PDL1 is something different.
All right, well, you take it away with PDL1.
Right. So PDL1, or another complicated name, programmed cell death ligand 1. So basically, it's a protein that plays a role in the body's immune system. So we all hear about immune systems now with the COVID going on, how we are responsive to how our immune system responds to different attacks on it. So basically, when we have a tumor, it's like a foreign body in our, that we have in our bodies. And, there's going to be some sort of immune response. So our lymphocytes, the small blue cells, are going to attack those like a big tumor cells. And basically, we do have drugs that can block the immune system from killing the cancer cells. So I should not say actually it's worse. We have drugs that can actually increase our immune response, and actually those immune cells can kill cancer cells. So this is a very simple assay to do. This is not like what we talked about, EGFR, ALK, all these tyrosine kinase inhibitors, when you have to use like specialized machine, big platforms, very complicated interpretation. This is what could be done on a single slide. It's on a 2-3 millimeter of tissue that's taken either at the patient's time of the biopsy, or it could be surgical resection. It could be from pleural fluids as well, for example. And we stain it. We have we call them antibodies that we would apply on those glass slides. And we as a pathologist can see then these tumor cells staining brown or red, whatever color we want to use. We pathologists like colors to see. So, and then if there's a lot of brown or lots of red, we call these cells positive. And this is actually marker and information that we are going to give to our oncologists we give the number so you can see in the reports, 10% of the cells, 5%, 100%. And based on the clinical trials, we know that there are like many drugs nowadays, many approved by FDA. I almost have feeling like they're getting approved daily or expanding their applications, that then these drugs can be used depending on how much PD-L1 positivity, if you will, is in those cancer cells. And it's another complicated field, but oncologists very well know about it. Even pathologists know about it. Again, I said even pathologists because we don't treat patients. We just provide these information to our oncologists. But we know that there are different cutoff points that it can be used. And actually, based on those cutoff points, you may qualify for different, we call them immune checkpoint inhibitors. And it's a large landscape. And again, I should say, this is just, testing is just one component of the decision process. There are other components as well, like, as you mentioned before, tumor stage, your physical status as a patient. Can you tolerate these therapies? Because these type of the therapies, immune checkpoint inhibitors, they may have more side effects than like the TKIs that we talked about. So, your provider will decide based on a complete picture and on the existing clinical guidelines and what's basically represented as the standard of care, whether you qualify for these or not.
Okay, so with PD-L1 treatment, is the order of treatment important?
That's a really clinical question for the oncologists. It's what's frequently done is that we basically test for the TKI biomarkers that we talked about first. And if patients are positive for those type of the biomarkers, they would get those specific biomarker therapies. So if you're testing positive for EGFR first, you are going to get EGFR tyrosine kinase inhibitor.
Okay.
If you test negative for all of these, then PD-L1 plays a role. But landscape is changing. Treatment, combinations. There are many clinical trials going on. Chemotherapy is not entirely out of the picture. There are different combinations of immune therapies, chemotherapy. It's a really very complicated landscape. But it's important that patients talk to the providers who can educate them about, what are the options. But the bottom line is like, there is not just one option for the lung cancer. There are multiple options, and I hope we are really living in the era of personalized approach to those tumors that we can treat with the different options that are out there. We certainly have more than 10 years ago.
Well, you answered that perfectly. And it also sounds like even when, and you had raised this point before, even when you're getting your care, you could be getting testing throughout, and things could change during your treatment process as well. So unfortunately, there's not one specific course, and the course can change. So it's hard, particularly when you're being treated with cancer, that you don't know what that trajectory is going to be, and flexibility is key.
That's right. That's absolutely true, because disease changes, treatment changes. So it's important to test at the different points, depending on the clinical judgment and the development of the disease.
Okay.
Or the progression of the disease.
Okay, perfect. So now that we've discussed biomarker testing for advanced non-small cell lung cancer, can we move on to biomarker testing for early stage non-small cell lung cancer?
Absolutely. That's completely new involving field. And the first marker that's, again, everything starts in the lung with EGFR, it sounds like it. We talked about advanced lung cancer a lot today. So advanced cancer, you may also hear stage 3B or stage 4 disease. Mm-hmm. Here you may hear like early. So what's the early stage disease? Usually we think about surgical disease. And it's like a stage 1 or 2 disease. And traditional thinking was that, once you get the surgery, you don't need anything else. This is it for the early stage disease. And then unfortunately, about 25% of the lung cancer patient with stage 1 disease will come back in 2 or 3 years with tumors somewhere else, either at the primary site of the surgery or even metastasis. So we are talking about recurrence. And recent trials that were presented actually at one of the big meetings, ASCO meetings last year, showed efficacy of EGFR targeted therapies in adjuvant setting, which means once you receive the surgery, your tumor is out, It's been tested for the EGFR, tested positive for EGFR, and now patient gets treated in adjuvant setting. This is something very common that we've seen in the breast cancer. Breast cancer patients all get like some sort of adjuvant therapy. And we see this now, this move in the lung cancer as well. So what that means from the testing standpoint is that we have to have discussion as a healthcare provider with our patients. Should we test surgically resected disease? And new guidelines for the testing are coming out very soon. I have a privilege to be part of one of those guidelines coming out in the next year. And I hope that recommendation and data will be even stronger than they're now, because the trial data were very strong, basically advocating that we should also test in the early stage disease. So we are getting into that direction. Are we there yet in like a large landscape, global landscape? Not, I don't think we are there yet, but in a bigger academic centers, in like big cancer centers, all stage lung cancer testing. So my hope is that testing in the lung cancer will be stage independent, like what we see in the breast cancer. We test at the time of the diagnosis, so hopefully we'll have the same for the lung cancer in the upcoming years. And EGFR again is paving it that way for the testing for the in early stage disease. I'm hoping that other tyrosine kinase inhibitors will show similar results that we've seen with the EGFR, which would mean we are not going to test just again for just one marker in the early stage disease, but like a really for the whole spectrum of markers that we talked about earlier in this presentation.
Okay. And can you touch briefly on biomarker testing for small cell lung cancer?
Yes, small cell lung cancer is a slightly different than, not slightly, it's a quite different disease actually than the non-small cell lung cancer. And unfortunately, we do not have tyrosine kinase inhibitors as a treatment for the patients in a small cell lung cancer. But there are some recent exciting data about the role of immunotherapy, that when we talked about PD-L1, when we talked about these immune checkpoint inhibitors, and some very promising and optimistic results in a small cell cancer, which means that we are going to test small cell lung cancer for PD-L1. So the landscape of testing is much smaller. So we are not using those like a big complicated assays. There should not be any issue with insurance, because this is just another stain that we do in our lab. It's not an expensive test. So small cell cancer is, as it stands right now, there are some other developments that are also making this whole picture quite complicated. But the bottom line is like immune therapies may play a role in the small cell lung cancer, and therefore we can test for PD-L1.
Okay. So to summarize what we've talked about so far, we've talked about a lot of different types of testing, and the recommendation, Dr. Dacic, wouldn't you say at this point would be, there's so much information out there, so these cancers vary. Seek your opinions of your healthcare providers, talk to your oncologist, who's really key and critical in helping you make decisions. Absolutely, feel free to research, but talk to your healthcare provider about what is critical and important for your treatment and your type of cancer.
I absolutely agree with that. And I think the conversation should take place. And sometimes information that you, and also I would like our patients to understand that this decision process for oncologists is not simple. It's actually very complicated. So those drugs actually that are approved, they are approved for to actually for specific scenarios, let's put it that way, because there are many factors that decides whether someone is going to receive this type of the therapy, whether a patient qualifies for this type of the therapies. It's not just the one factor that's going to be the deciding point. So it's a multiple factors. But I believe it's extremely important to talk to the provider about it. It's extremely important to bring up the question of biomarker testing if you are not offered this, or if it's not mentioned in the discussion, because again, you may have a tumor type that basically doesn't qualify for this. We didn't talk much about squamous cell carcinoma today, but there are different types that are not, we are not that much advanced in terms of the targeted therapies like in adenocarcinomas. but I think that a conversation should take a place. And, and I should say here as well, don't be afraid to ask for second opinion. I mean, it is all right if you are not very happy with the explanations that you received or satisfied with the explanations you received, ask for second opinion, because it's a very complicated field. It's a really complicated field, and it's changing almost, like, as I said, weekly in terms of the recommendation what should be done. There are many experts in the field. They can give you the answers. They can guide you through this thing. But it's important to ask the questions. Either you or your loved ones or family members, friends. There's a cancer support team. We are here for you. So just feel free to reach out, and hopefully we can help.
And often I would say that your healthcare professionals would expect that sometimes you seek a second opinion. If you're going near a community hospital and you want to go to a larger university setting, and they will actually, your navigators and your healthcare team might give you the name of somebody you should seek that opinion to. And often people will go and then they come back to their local. So there's no harm in asking for a second opinion.
I absolutely agree, because, as I said, it's a very complicated landscape in terms of the treatment, in terms of the testing, and it's good, it's good to get second opinion if needed. If needed, you may be happy with your provider, you may get like a standard of care, but sometimes you may not be happy, and it's perfectly fine to go out and seek opinion, and then you can come back and basically get the treatment that was recommended and what's best for you, because it is complicated. It's not simple.
Absolutely. So now it's time to cover one more important topic. But what I want to say is, if anyone has any questions, please, now it's time to put them in the chat. So a couple more conversation points, Dr. Dacic. I wanted to go over what resources are available to help our patients be advocates for themselves regarding getting biomarker testing. So to start, for more information about biomarker testing for lung cancer, you and your loved ones can visit our biomarker testing tool at www.cancersupportcommunity.org/biomarker testing tool. Our biomarker testing tool is designed to help lung cancer patients and their caregivers navigate the biomarker testing process. But Dr. Dacic, what if the cancer team tells our patients they don't need biomarker testing? Is that when they should seek another opinion? When do our patients know, well, maybe I do, maybe I don't? What do you recommend?
It really depends on a clinical scenario. Sometimes it's a time issue. And unfortunately, for some of our patients, they may be diagnosed as such advanced, rapidly progressive disease that biomarker, even if it could be considered potentially, it's just there is not enough time. And that's unfortunate for some of our patients, because these tests, they can take, we didn't talk about, how much time these tests takes. If it's done in a big academic center, kind of like we make the testing at the time of a diagnosis, it will still take up to 10 business days, which means 2 weeks. And for some patients, that could not be enough time. And sometimes if it's not done at the hospital where you're initially diagnosed and your health care provider is, and your samples have to be sent out to the outside laboratories, it could take up to like a month, sometimes 6 weeks. So time is a huge issue, and it could be a huge deciding factor. And if we are talking about really advanced and rapidly progressive disease, and that could be one of the reasons why, even though your tumor may be positive for EGFR or ALK, but there's just not enough time to test, you may be given some other therapies just to relieve the symptoms or to help you, because unfortunately, there's still some of those patients who are coming with a very advanced disease where the time is an issue. So that could be one scenario. Another scenario is that you may have a tumor type, for example, that should not be properly tested. And we didn't talk that much about histology of these tumors or these specific subtypes, because I think it's a topic for itself and maybe too complicated. But if you hear, for example, squamous cell carcinomas and, history of patient who is like older, I'm not going to put specific the age here, but older patients, smokers or current smokers with squamous cell carcinoma, it's very unlikely that you are going to have EGFR mutations. If you are younger, if you are 35 or 40 and you never smoked, or maybe you were a secondhand smoker, so you were surrounded by smokers, but you never actively smoked, and you have a squamous cell carcinoma, you should be tested for biomarkers, because this is 1% of our squamous cell carcinomas that have EGFR mutations. So it really depends on the clinical scenario. But if you if the disease is like not rapidly progressing, and clinically you are relatively speaking fine, and and this was not brought up, biomarker testing, you should ask about it, and see what are the options. And the provider didn't provide, didn't want to test for it, you should ask, why am I not getting tested? So I think it's a valid situation to ask. But as I said, for some unfortunate situations, there's simply not enough time to get the results and start the treatment.
Perfect. So in addition to the resources that are listed on the screen, our cancer support helpline, 888-793-9355. We have this helpline, and we have navigators that are available Monday through Friday, 9 a.m. to 9 p.m. Eastern Time, and on weekends from 9 a.m. to 5 p.m. Eastern Standard Time. And the staff by our navigators and resource specialists who are available to assist you, help answer questions, help give you the tools to decide what questions to ask your physicians, and how to help frame that for you and your loved ones. You can also visit mylifeline.org for additional community support and connection. So before we wrap up, there's one or two questions that our patients have asked. But Dr. Dacic, first of all, you are a true expert and have been absolutely wonderful today. So we want to thank you for your time, for your expertise, and for everything that you're doing to help advance science and to advance biomarker testing and all that you're doing. So thank you to you.
Yeah, I would like to thank you again for the opportunity to be part of this program. It's my privilege, and I will do whatever it takes for my patients.
We can tell. Absolutely. You're a true patient advocate. We would also like to thank our sponsors who made this program possible, and that is Bristol Myers Squibb, Amgen Oncology, and Merck. So one or two last questions, Dr. Dacic, and we know that your time is valuable. So we will knock these in the park. Somebody has asked, is it possible to be positive for more than one biomarker?
It is positive. It's possible to be positive for more than one biomarker, that's for sure. The one that we talked about today are mutually exclusive. For example, EGFR and ALK are mutually exclusive, which means if tumor is positive for ALK, it's not going to be positive for EGFR. One marker that could be present as well, for example, is a PD-L1. PD-L1 is independent, relatively speaking, independent of the other genes. So you can get like a EGFR and PD-L1 positive tumor. You can get KRAS and PD-L1 positive tumor. But generally speaking, the ones when we talked about targeted therapies, these ones are considered to be mutually exclusive. So it's one or the other. But there are other biomarkers that are coming into the landscape of biomarker testing. But it's too complicated. It's way beyond where we are today. So maybe like a year from now, we can talk about it. But at this point, PD-L1 is one that can coexist with other biomarkers that we talked about today.
Okay, two more questions for you. How long does it typically take to get biomarker testing results?
I touched upon a little bit. It depends really. If it's done in the hospital where the patient is seen and diagnosed, and there is a protocol in place to get testing done at the time of the diagnosis, PD-L1 could be at the same time as the primary diagnosis or histological diagnosis. The other markers that we talked about today is usually, it cannot be more than 10 working days. That's basically the recommendation for us from the laboratory standpoint. But unfortunately, if the sample has to be sent out and the testing is not done in kind of like a reflex or automated way, then it can take up to a month.
Wow. So it really does vary, as you said.
It does vary. It does vary.
Yeah. So one last question for you, Dr. Dacic. If we were to come back 10 years from now, on this day, right before the holidays, what would your hope be regarding biomarker testing? What would you like to see regarding advancement?
Yeah, I hope that we are not going to have discussion about who should get biomarker testing. I think all cancer patients, because what we see in the lung cancer, we see in other tumor types as well. But I believe that it should be standard of care. I believe that every single patient will be able to get the biomarker testing, and we will not have these discussions about cost of the testing, who should qualify, who should not qualify. Everybody should get it, and I hope we are going to live in a true era of personalized medicine and personalized cancer treatment.
That is a perfect statement to end today's conversation. And we here at Cancer Support Community completely agree with you. We want to empower our patients. We want you to advocate for yourselves. Your physicians and your healthcare team, like Dr. Dacic, are advocates for you, as we are here at Cancer Support Community. So on that note, Dr. Dacic, it's been an absolute pleasure wishing you and your family and your patients a happy and healthy and safe new year. Thank you so much.
Thank you so much. Happy New Year to everybody.